Okay, guys, so good afternoon. I think maybe we can start with the presentation since we're on a Sunday and I don't want to take too much of your time. But do you think we can go ahead, maybe?
Yeah, I think yes.
Yes, you can.
Okay, so thank you all so much for coming today, and thanks to MIMSA for organizing this session. My name is Carlota Baptista. I graduated from Masaryk University back in 2019. I'm a fourth-year medical oncology resident in Loures, Portugal, near Lisbon. And over the next 2 weeks, I'll be having these sessions with you to explain you some key concepts about oncology that I hope will be helpful for your exams and for the future, okay? So, first of all, what is oncology and what does an oncologist really do? So, oncology is the specialty that cares for the cancer patients as a whole. So we go from the diagnosis, staging of the cancer, treatment, management of cancer and treatment-related complications, disease monitoring, and follow-up. So, you know, when I was in med school and people would ask me what specialty I liked, and I would say that I liked oncology, people were instantly very concerned. Aren't you going to be very sad? And isn't oncology a really depressing specialty? And I understand their worries, but so I asked, I have my own opinion now since I'm a fourth-year resident, but I asked ChatGPT since nowadays AI, they have an answer for everything. And of course, oncology is a really taxing specialty in the sense that it deals with patients with a life-threatening illness, and it's very hard to deliver difficult news of disease progression, of relapse, and it's hard to have these conversations with patients, but it's also with great satisfaction that we can be present for them and for their families during this very hard and difficult time of their life. And I think that the bond that you establish with patients in oncology is really different from the one that you establish with patients in other specialties, because you become their primary doctor. People often say that oncologists are the GPs of cancer patients. You know, the patient will come to you for everything and anything. Okay, so I think it's really an honor to be able to be there for the patients. And of course, nowadays we have a lot of new therapies being developed, and I think we have been experiencing great advances in oncology, and we can prolong this patient survival, we can improve their quality of life, and we can offer them more and more each day. Okay, so I think it's a really special field in medicine, and I hope maybe some of you will consider it for the future. So, like I said just now, it's a rapidly evolving field. I don't know if any of you have heard about this trial. This was really all over the news maybe 6 months ago. There was this trial in patients with locally advanced rectal cancer. You know, these patients, usually the standard treatment is with chemoradiation, and then they go into a watch and wait strategy. So we follow them and we see if the cancer comes back. So if it comes back, the patient has to go a really extensive surgery with a lot of morbidity. If it doesn't, then the patient goes on follow-up. So what they tried in this trial was to do some induction treatment with an immunotherapy, a type of immunotherapy. It's this drug here, it's the dostarlimab. And this trial was a very small trial. It included only about a dozen patients, but really all the patients in this trial, after receiving the drug, they had a complete response. So the disease totally disappeared. And I think this is something, is just one example of the great things that we can sometimes achieve in oncology. And I hope it leaves us with some hope for the future, because if we look back in time over the past 30 years, the past 40 years, and this picture here is a bit outdated now, we have seen a great survival improvements in many types of cancer. Of course, there are some where the survival hasn't improved that much, like pancreatic cancer. It's still our nemesis. We aren't able to do much about it, unfortunately. But there are some types of cancer, in this picture nowadays would be even better, for instance, for lung cancer and breast cancer, where we have seen with these all new therapies great survival advantages, okay? So this was just some small introduction. And now I want to start with some fundamental concepts in oncology that I hope will help you understand better what we do in clinical practice, and that you can understand it better as well than when you're studying for your oncology exams. So what's our scope of intervention? As I've told you before, we are concerned about the diagnosis, the staging, the treatment with curative intent, the treatment with palliative intent, and throughout the whole treatment, the supportive care. It's only possible to deliver effective treatment if we have good supportive care. Otherwise, our patients will have serious side effects that will cause delays in treatment interruptions, and these will then affect their outcomes. So good supportive care is a mainstay of our treatments in oncology. So first, I'm sorry, I'm a bit under the weather, so I'll just drink some water. First of all, the diagnosis, what we all know. So the clinical signs and symptoms. Patients can present with non-specific symptoms, like a constitutional syndrome with weight loss, loss of appetite, with fatigue, but these are usually signs of a more advanced disease, okay? Where there's a lot of pro-inflammatory signals that will cause all of these symptoms. Usually patients with earlier disease or locally advanced will have site-specific symptoms. For instance, in breast cancer, a breast lump, or a change in bowel habits in colorectal cancer, or hoarseness in head and neck cancer, and so on. The blood work is not very specific, as we already know. It can sometimes help us. A patient with iron deficiency anemia, we can think about colorectal or any kind of digestive cancer and ask for some endoscopic studies, but usually it's not very helpful. And as you already know, probably most tumor markers are not very useful in cancer screening and diagnosis. However, there's a single exception to this rule, and there's a tumor marker that can help us in cancer screening. Do any of you know which one is it? Just to see if you're paying attention. Does anyone want to risk it? So if not, I'll say the answer. So it's the PSA, the prostate-specific antigen. It's used in the screening of prostate cancer. Then the imaging studies, the oncologist's best friend. So we have the CT scan, the MRI, the ultrasound, and the X-ray. The X-ray is not very useful, but still can have a role sometimes. And then the functional exams. Nowadays we have these very sophisticated exams like the PET scan. It will show you a metabolic increase in activity in places where the cancer is located. And the most commonly used is the PET FDG, okay, which uses glucose. And then we have the PET gallium, which is used, for instance, in neuroendocrine tumors, the PET PSMA in prostate cancer. And then we have the bone scintigraphy, which is useful in the staging of cancers that metastasize to the bone. For instance, in breast cancer and in prostate cancer, it's very good in showing us the sites of osteoblastic lesions, but also osteolytic. And then the mainstay of diagnosis is the biopsy. It will confirm us what histological subtypes the cancer is. Sometimes we have cancers of we have this entity that is called the cancer of unknown primary. So sometimes we have a patient that has metastasized disease, but we can't really, with our conventional exams, the CT scan, the PET, the endoscopic studies, see where the primary tumor is, and the biopsy can tell us, the biopsy of one of the metastases can tell us this is a tumor from the digestive tract, or this is a tumor of the breast, okay? And it will help us tailor treatment, is really fundamental. Okay, so a bit more about the tumor markers. As I said before, they're not very useful in diagnosis and screening. So the exception for this would be the PSA, but you use some of them. We have a few of them. Not all of them are here, but I put here the ones that I think are most commonly used. So we have the CEA for digestive cancer, very important in colorectal, and also can be expressed in breast cancer. The PSA I already told you. Then we have the CA 15.3 in breast cancer, the CA 19.9 in digestive cancer, colorectal, gastric, biliary, and pancreatic, the alpha-fetoprotein for hepatocellular cancer and testicular cancer, and the CA 125 for ovarian cancer. Okay, so can you tell me what's the main use of tumor markers? So we know we don't use them in diagnosis and screening, so what's their utility?
For staging?
Monitoring the treatment.
Exactly. Yes, and then also
for the recurrence rate.
Yes, exactly. Perfect. Okay, so after the diagnosis, we have to take the whole picture, okay? We have to see where the disease is. So we do the staging. The staging defines the anatomic extent of the disease. It allows us to plan for treatment because we will treat the patient according to the staging. It allows us to establish the prognosis and evaluate the efficacy of our treatments, okay? It also makes sure we're all speaking the same language, because in oncology, we use the same guidelines. You know, we use the ESMO guidelines, which are the European Society. We use the NCCN guidelines. So this makes sure that no matter where we're treating our patients, we can all follow the same guidelines, okay? So the one that is most commonly used is the TNM. I won't ask you what it stands for because it's already here and I think you already know it. So the T is for the primary tumor, the N is for the regional lymph nodes, and the M is for the distant metastases, okay? There are also some other staging systems specific for some types of cancer, like the Ann Arbor for lymphoma, the FIGO for gynecological cancers, and the Clark and Breslow for malignant melanoma. And these have some particularities. They do not follow this scheme of the TNM. And then, just as important as staging and making a correct diagnosis is being able to correctly evaluate our patient's performance status. I don't know if you're familiar with this term, but this is something very important in oncology, okay? Because we can't follow just, we can't just see, okay, this patient is a stage 4, and the guideline tells us to do this treatment, and then we won't look at the patient that is right in front of us, okay? So we have to see how fit or how frail the patient is, because we know that patients with a worse performance status will tolerate our treatments worse. We never want to give the patients a treatment that will cause them an acceptable toxicity. So the most frequently used tools are by far the ECOG performance status and the Karnofsky scale. I think maybe you've heard of them. The one that is most commonly used is the ECOG. It's the one that it's used in almost all clinical trials for the development of anti-cancer drugs. And it's one that we use daily, not only at diagnosis, but also during treatment, to see how our patient is being able to tolerate our treatments, okay? So it's kind of similar to the NIA scale for heart failure. So a patient with a ECOG 0 is one that is able to do anything, someone just like us. Then a patient with a ECOG of 1 is someone that can't do physically strenuous activity but can do almost everything else. A patient with a ECOG of 2 is one that is up and about more than 50% of waking hours. An ECOG of 3 is a patient that is confined to the bed or the chair more than 50% of waking hours. And an ECOG of 4 is a patient that cannot do any self-care and is totally confined to a bed or a chair. As you can imagine, these patients will not benefit from anti-cancer treatment, and these patients should be referred to palliative care. Okay, so this is something really important, and being able to determine and assess the ECOG of the patient is something that will also come from your clinical experience, okay? In oncology, chronological age is not as important as biological age. You know, you can have a patient, for instance, I have this patient in my clinic. She was recently diagnosed with stage 4 cholangiocarcinoma. She's an 8-year-old lady, but she still works as a nanny. She goes camping, she does gymnastics, she does more than I do. So she's a really fit patient, and we will offer them the standard treatment. But sometimes you can have someone that is 50-year-old, but they have a lot of comorbidities. They are really thin, and these patients with a worse ECOG, you have to do a de-escalated treatment, something a bit more soft, so they will be able to tolerate it. Okay, so I've told you about all the advances in cancer care. You already know about the surgery, the radiotherapy, the chemotherapy, but nowadays we also have these newer treatments like the targeted therapy. It is a specific therapy that is works against some specific molecular alteration that can be expressed by some types of cancer. And then we have the immunotherapy, like the one I told you in the beginning of that clinical trial with dostarlimab. Immunotherapy has revolutionized the treatment of cancer, and we use it in almost all types of cancer nowadays. It has a role, and it's dramatically changed the outcome for our patients. What it does, it helps our immune system to recognize the cancer cells and attack them. Then we have different treatment goals. We can treat patients with curative intent, with palliative intent, and we can do some conversion therapy. So we can turn a metastatic disease into a disease that we can potentially cure. When we treat a patient with curative intent, our goal is to eliminate all the disease that we know that the patient has, okay? And we want to reduce the chances of relapse, because even if we treat a patient with curative intent, we operate and we do adjuvant chemotherapy, we know that there is a chance that 3 years down the line, 5 years down the line, 10 years, the patient can relapse, okay? So we need to do the most aggressive treatment we can to decrease this risk, okay? So we will most often in this case risk some toxicity in order to potentially cure these patients. Sometimes we're dealing with patients who are really young, so maybe we're able to risk some peripheral neuropathy, some more vomiting and nausea, some more side effects, if we know that we can give them a whole life ahead of them, okay? Chemotherapy is rarely curative in isolation. Usually, curative intent treatment is only possible if we do multimodality treatment. This means chemotherapy, usually surgery, and we can do radiotherapy or not. Then, palliative intent. Our main concern here is the quality of life, okay? It's not the same as palliative care. We still can do anti-cancer treatment, and we can still try to attain some survival gain, but we treat the patient less aggressively. We are more concerned about their quality of life. We don't want to risk as much toxicity as in the curative intent. But you know, sometimes nowadays we have, for instance, in stage 4 colorectal cancer, stage 4 breast cancer, we can have patients who live more than 5 years, you know. So it's not such the prognosis is not the same for every kind of disease. Even in palliative intent treatment, we can have prolonged survival. Conversion therapy, I'll give you an example here. So sometimes we have patients who have colorectal cancer and they have only a few liver metastases. In these patients, we can do chemo. We try to downsize, so reduce the size of the tumor, and then we can operate on the primary tumor and on the liver metastases, and we render these patients free of disease. Then we usually do adjuvant chemo after, but these patients can be cured of a disease which was stage 4 at diagnosis. Then, in which ways can we do chemotherapy and other therapies? This can also apply to immunotherapy, for instance. This is always in the curative intent treatment, but we can do it neoadjuvant, adjuvant, or concomitant. Neoadjuvant therapy is one that goes before the primary treatment, which is usually surgery. It helps us reduce the size of the tumor to facilitate the surgery. It also eliminates the micrometastases. You know, we always think that a cancer, no matter if it's localized, it is shedding some cancer cells into the circulation. And these cells can stay dormant, and many years down the line, the patient can have a relapse. So if we do neoadjuvant chemo, if we do a systemic treatment prior to surgery, we can help eliminate these micrometastases and reduce the risk of relapse. So one example is, for instance, in a patient with breast cancer who has a very big tumor and a small breast, we can do chemotherapy before the surgery in order to be able to offer this patient a lumpectomy or a breast conserving surgery. Adjuvant therapy, the goal here is to reduce the risk of relapse after curative intent treatment. An example of that would be in pancreatic cancer, because unfortunately, pancreatic cancer, you know, even patients who have surgery, who have localized disease, around 80% of them will have a relapse in the first 5 years after surgery. So every single one of these patients has indication to do at least 6 months of adjuvant chemotherapy to reduce this risk. Unfortunately, most of them will still relapse. And then the concomitant treatment is with chemoradiation. This can be done, for instance, in locally advanced rectal cancer and in locally advanced head and neck cancer, where we do the chemotherapy and the radiotherapy at the same time. And the mainstay of the treatment here is the radiotherapy, and the chemotherapy will only act as a radiosensitizer. Okay, so these were the fundamentals of oncology. I'll now go on to the breast cancer specifically. I don't know if you have any questions now. If not, I will continue. Okay, so just drink a bit more water. So, breast cancer. So it's the most common cancer worldwide, and it's the #1 cause of death from cancer in women. Its incidence has been increasing over the years. You know, cancer is a disease of aging. So since we're living longer, the incidence of cancer is also increasing. And also because, as you know, breast cancer has a populational-based screening. So if we're able to detect more, then the incidence will also increase. But fortunately, the mortality has been decreasing because we have more and more effective therapies. The risk factors are being a woman, the incidence in men is around 1%, advanced age, early menarche, late menopause, the first pregnancy with more than 30 years, the use of combined birth pill control, obesity, alcoholism, and the family history, and the BRCA1 and 2 mutations. The screening with mammography is recommended between the ages of 50 until 69 every 2 years. And then we can classify breast cancer according to some different classifications. We have the histological classification, which is something different than what I'm showing you here. The histological classification, usually the most common type is the one that was previously called the ductal carcinoma. Nowadays we call it non-special type. And then we have the lobular carcinoma, which is a bit more aggressive, okay? But the most frequent are the no special type or ductal, okay? Then we have the biological subtypes, and these are given to us by immunohistochemistry. And these are very, very, very important for deciding treatment, okay? Usually when we do our department presentations for the treatment of breast cancer, it's usually 6 or 8 presentations just speaking of each of these subtypes individually. So it's something that it's very complex to tell you in just this presentation today, but I hope that you can have some key concepts that you can take for your life and for your exam. So basically, we can divide breast cancer biologically into 3 subtypes. The first one are the luminal breast cancers, okay? These are the ones that express hormone receptors like progesterone and estrogen. These are the most frequent, they are the less aggressive, and they have the best prognosis. Then we have the HER2 positive, and I'll show you in the next slide what HER2 positive means, okay? These are somewhere in the between, okay? And then we have the triple negative breast cancer, okay? So does anyone know what a triple negative breast cancer means or what it is? Okay,
That
so
it has none of the receptors, not the estrogen, progesterone, or the HER2.
yes, exactly, perfect, okay. That's exactly that, and this is the one that is the least frequent, but is the one with the worst prognosis by far. So, talking a bit about HER2 positive breast cancer, because this is a really interesting type of breast cancer. A normal cell will usually express HER2 receptors in a normal quantity. HER2 positive cells will have a lot of HER2 receptors, and this will cause the cell to very rapidly divide and will lead to a very aggressive cancer. These cancers used to have a very bad prognosis, but the truth is, nowadays we have the anti-HER2 therapies, like for instance trastuzumab, and these therapies have improved the prognosis of HER2 positive breast cancer dramatically, okay? Because it used to be nearly as bad or maybe worse than triple negative, but because these therapies are so effective, they are one of the most spectacular anti-cancer drugs that were developed in oncology. They really changed the landscape of treatment of these cancers, and nowadays they have almost as good a prognosis as luminal breast cancer. Not because the cancer is indolent or has a good behavior, but because the therapies are so effective. About the clinical signs, so most patients will present with a palpable lump. There can be other signs like nipple retraction, the peau d'orange, a bloody nipple discharge, skin ulceration, and then you can have the enlarged lymph nodes. Usually the axillary are the ones where the breast cancer goes first, but we can also have cervical lymphadenopathy or supraclavicular lymph nodes, or of course signs of distant spread. There is a special subtype of breast cancer that is diagnosed clinically, that is the inflammatory breast cancer. It's very important that you're able to recognize it. It's a type of locally advanced breast cancer. It's always an indication for mastectomy, and you can see here in this picture that the breast of this lady, it looks really, it's usually very warm. The skin is very thick, and sometimes it looks like an infection. Sometimes these patients will go to the GP, and this will be confused with the mastitis, and the patients will go on to take antibiotics, but they won't get better. Okay, and this is usually a very aggressive type of cancer, and the patients are always staged as locally advanced, and this is a clinical diagnosis. Okay, it's something that you recognize clinically. Then after diagnosis, after the clinical diagnosis, we have to do the formal diagnosis and the staging. So what do we do when we have a patient with a suspicious breast lump? We will do the clinical examination, check the breast, check the lymph nodes. Also, we'll ask for a mammography, a breast ultrasound, and almost in every case, also a breast MRI. It can sometimes detect lesions that are not easily seen on mammography or on breast ultrasound, and it can change our staging. Okay, we also do the axillary ultrasound. It's usually done at the same time as the breast ultrasound. We, of course, always do the biopsy. Usually we prefer a core biopsy because we will have a larger sample and we can do the immunohistochemistry to understand which one is the biological subtype of the cancer, and then to define if there are or not distant metastases. We can do in most cases a CT scan and a bone scintigraphy, but in low risk women with small tumors without positive lymph nodes, we can do just an abdominal ultrasound and a chest x-ray. Okay, the tumor markers, as we said before, do not have a role in the diagnosis of breast cancer. Okay, they are only used for monitoring, especially in metastatic disease. Do you remember which tumor markers are associated with breast cancer?
CA15-3.
Okay, right, and sometimes CEA, but not so often. Then the treatment. I think it's really hard for your teachers to demand you to really explain how it goes for the treatment of breast cancer. It is an extremely complex topic. The guidelines are different for the different biological subtypes, so the luminal, the HER2, and the triple negative breast cancer. And it takes into consideration, of course, the TNM staging, the performance status of the patient, their comorbidities, and their wishes, of course. So I'll try to give you some fundamental concepts, but just know that is something very summarized. It's impossible for you to know this. It's hard even for oncologists. We have to check it all the time. So most patients with early localized breast cancer, we will try to do a breast conserving surgery or versus a mastectomy. Of course, we will always want to preserve the breast. Patients who will have to undergo a mastectomy, we will try always to offer an immediate reconstruction. Okay, this is very important as well. Sometimes, even if we do neoadjuvant chemotherapy before the surgery, there are some patients who will always from the get-go have indication for mastectomy. If you remember the inflammatory breast cancer, you have it all over the breast. It's because of the dermal lymphatics infiltration by the cancer cells. So it's everywhere. It makes no sense to do a lumpectomy. Some patients have a tumor size that is very disproportionate to the size of the breast, even after neoadjuvant chemotherapy, or sometimes you think, even with neoadjuvant chemotherapy, I will not be able to reduce the size of this tumor. So these patients will from the get-go be indicated for mastectomy. Patients with multicentric tumors, this is also an important concept. So you can have a lesion that is just in one side of the breast, and it's easy to do a lumpectomy. And you can have a multifocal breast cancer. You can see here in the picture on the right, multifocal is when the lesions are all in the same quadrant of the breast. Okay, you divide the breast into 4 quadrants. The multifocal breast cancer, the lesions are all in the same quadrant, and it's possible to do a breast conserving surgery here. If you have a multicentric breast cancer, it means that the lesions are in different quadrants. It's always an indication for mastectomy. Then another important indication is the T4 tumors. T4s are the cancer that are growing into the chest wall. So these patients can never do breast conserving surgery. All patients who have a breast conserving surgery have to do adjuvant radiotherapy to the chest wall. We know from clinical trials that were conducted many years ago that this reduces the risk of relapse and improves overall survival. Patients who have a clinically negative axillary lymph nodes, who are an N0, have to do the sentinel lymph node biopsy at the time of surgery, and patients who have clinically positive lymph nodes at the time of surgery will have to do a lymphadenectomy, okay? This is when the patient goes straight to surgery. Patients who have a clinically positive lymph node in the axilla and receive neoadjuvant chemotherapy, it's a bit more complex topic if they will undergo lymphadenectomy or not on a second time of surgery, okay? So I think this is outside the scope of what you need to know for med school. Almost all patients with triple negative breast cancer or HER2 positive breast cancer will receive neoadjuvant chemotherapy because we know these are very aggressive tumors. We want to eliminate the micrometastasis, so we will start with systemic treatment first, and then we will go to surgery. And then the decision about offering the patients adjuvant chemotherapy after surgery is also a very complex topic in oncology, also outside the scope of what I think you have to know. In some patients, we can have some genomic risk stratifying tools. We do some cool things with genomic tests. This one here is an example which we use in clinical practice. It's called the oncotype diagnosis. Basically, it takes the surgical specimen and it does a genomic analysis, and then we receive an email with exactly these results that tells us what is the risk of recurrence of our patient and what is the benefit of doing adjuvant chemotherapy. Because sometimes it's a gray area. Sometimes we have some patients we know that they have to receive adjuvant chemotherapy. We have some that we know that they don't need it, but sometimes there's a gray area, and in these cases we sometimes do the oncotype diagnosis, okay? Patients with hormone receptor positive breast cancer will always receive adjuvant hormonal therapy for at least 5 years. The treatment of metastatic disease will differ according to the biological subtype. It remains an incurable disease, but as I've told you before, some patients can have a very prolonged survival. I don't know if you had this idea, but just to let you know, around 40% of patients with HER2 positive metastatic breast cancer are alive 8 years after diagnosis. I think this is really something very impressive. So not one size fits all. We have to take into consideration the performance status of the patient, the comorbidities, and all these other things I've already told you about. Usually in luminal breast cancer or hormone receptor positive breast cancer, we will do first-line treatment with hormonal therapy and with these new drugs, which are called the CDK4/6 inhibitors. The only exception when patients with a luminal metastatic breast cancer will start with chemo is when they are in a visceral crisis, okay? And visceral crisis is when the patient has symptoms or organ failure due to metastasization, okay? It's not enough to have liver metastasis to be considered to be in visceral crisis. The patient has to have a liver failure. And these patients will start with chemo because we know that chemo is able to act faster. So we want to save save them from that clinical condition they're in. Then for HER2 positive, we will most often start with chemotherapy plus the anti-HER2 drugs, usually a combination of them with trastuzumab and pertuzumab, and with triple negative breast cancer, which is the one with the worst outcomes, unfortunately, we start with chemo, okay? Then my last slide. For the follow-up, the patients who are I'll start with the ones who are still being treated in the metastatic setting, since we were talking about it just before. We usually ask for the imaging every 3 to 4 months to see how the disease is responding to treatment, if it's stable, if there's a response, if there's a progression. Of course, you can ask for it earlier if you have a clinical suspicion of disease progression. And we can also use the tumor markers if they were initially elevated to guide our management. Then for patients who have undergone curative intent treatment, we do the clinical exam. So we see the patients every 3 months for 2 years, then every 6 months for 3 years, and then annually. We do the breast mammogram and ultrasound annually, and we recommend the gynecological exam annually for patients taking tamoxifen, because we know that there is a small increase of risk of endometrial cancer. Okay, guys, that's it. I hope I didn't take too much of your time and that it was helpful. I don't know if you have any questions. You have my email here as well. You can feel free to message me if you have any questions about these topics or some other topics in oncology. I'm happy to help. Thank you, Irene. I hope to see you next Sunday. I think it will be about colorectal cancer, I think, or lung. I don't remember actually, but I hope it was helpful, okay? Let me know if you have any questions. Feel free to email me, and have a nice Sunday.
Yes, thank you so much. It was very nice.